only 2 cases to teach you all the anatomy, and I think that itself may take about an hour, hour and a half. So for basic purposes, all basic purposes, I'm going to talk to you all on the facial anatomy and in terms of in terms of the T1 weighted imaging. So this is a standard. So what I'm going to show up here is initially a standard T2 weighted coronal image, which is put up here. Now, but the anatomy I'm going to completely teach you is on the T1 weighted imaging. So let's, for the sake of it, start off from the level of the pelvic brim. Just give me a second. I'll just tab these off. Give me a second, please. Okay, so let's look at the anatomy. I'll kind of briefly describe the pelvic facial reflections, starting off with this first case. So if you're keenly looking at the T2 weighted image setting up here, by and large, the first structure which I look for always in the pelvis is the sacrum and therefore the lumbosacral junction. And now this structure basically is a sacral promontory, and you have the pelvic brim or the pelvic inlet basically defined from the sacral promontory up to the level of the superior arch of the superior pubic, of the superior edge of the superior pubic arch. Now, when I look at this structure, this is very important because there's a key transition zone for certain facial reflections. Now, why is it so important? The pelvic facial reflections are basically a continuum of the retroperitoneal facial reflections. So they're not that these facial reflections exist in isolation, but they're just continuity of the retroperitoneal fascia. These facial reflections, when they go into the perineum, are then becoming contiguous with the facial reflections of the scrotum or the labial structures in women, and also more anteriorly with the superficial fascia of the anterior abdominal wall, which we know as the Camper and Scarpa's facial reflection. So what is the first facial reflection which you should always know? The first facial reflection is the visceral endopelvic facial reflection. Now, ideally speaking, when you look at the level of the aorta and the aortic bifurcation, so you know that the vascular compartment of the retroperitoneum has got 2 major structures, the aorta to the left and the IVC to the right. These 2 structures are basically a kind of a salami between 2 layers of fascia. The facial reflection ventral to the abdominal aorta and the IVC is called, is the anterior retroperitoneal facial reflection in the vascular compartment. But there's another facial lining which is located posterior to both these structures and ventral to the prevertebral facial reflection. And these 2 facial reflections are the key for you to understand what exactly happens when it goes down into the pelvis. So the structures which are located ventral, the facial reflection located ventral to the aorta and the IVC, when it comes down, it comes along with the sleeve of the vessels and the fat which comes along with, or the mesenchyme which comes along with these vessels. For example, if you have the inferior mesenteric artery which is breaking through the facial reflection and coming down, so we know the inferior mesenteric artery kind of gives out branch to the left colic, the sigmoid, and finally continues as a superior rectal artery. Now, when the superior rectal artery kind of comes down, it brings with it this anterior facial reflection. Now, this anterior facial reflection finally kind of goes down and envelopes the rectum and then gets contiguous with the posterior surface of the prostate. Now, this facial reflection is called the mesorectal, or what we would call the visceral endopelvic fascia. The visceral endopelvic fascia, which encompasses the mid-rectum ideally. So what you see on this section, this is the visceral endopelvic facial reflection. You see the structure, this structure, which I'm going to again annotate for you, represents the visceral endopelvic facial reflection. Now, this fascia has got multiple names. Ideally, it is called the mesorectal fascia when it encompasses the mid-rectum, which is the extraperitonealized form of the rectum, where it merges with the anterior or the posterior surface of the prostate gland. It tends to form a condensation, which is also called the Denon-Villiers facial reflection. Of course, all these facial reflections tend to be discontinuous, tend to have partial areas of cleavage, whereby nerves, vessels, and even medicine can get into these structures. So you have the visceral endopelvic fascia, which is kind of the central compartment of the pelvis. Of course, it only covers the extraperitonealized structures of the pelvis. So that's the prostate and the mid-rectum. The upper rectum is near completely peritonealized. The mesorectal fascia is located a little more posteriorly. So that's point number one. The junction at which the visceral endopelvic fascia, that is the mesorectal fascia, meets the seminal vesicles in men or in women, where it meets the outer edge of the uterosacral ligament as it arcs along the torus uterine, you have a very key structure which is very important in terms of the functionality of the pelvic diaphragm and the perineal structures, which is called the hypogastric plexus. You need to identify that in most of your cases of your pelvic floor, where your pelvic floor anatomy needs to be read very carefully. Once you're done with the visceral facial reflection, you should know that it's intimately related to what we call the parietal endopelvic facial reflection. The parietal endopelvic facial reflection is a continuation of the fascia at the level of the pelvic rim, which runs posterior to the aorta and the IVC. This facial reflection is intimately related to the vertebral column. Therefore, it is the sacrum and the coccyx, and what we have as the presacral facial reflection. Now, this presacral fascia is nothing but the parietal endopelvic fascia. Secondly, what happens is this parietal endopelvic fascia not only envelopes the portion of the sacrum, but arcs posterolaterally and tends to cover the piriformis bellies. Now, this is very important because at this point is where you have the entry of the lumbosacral plexus. Now, we all know that the lumbosacral plexus is a condensation between the ventral rami of the L4-5 trunk, which is part of the lumbar plexus, and the ventral rami of S1 to the S4 nerve roots. So this is a very important structure because any damage to the lumbosacral plexus is going to then have repercussions when you're looking at the pelvic floor in terms of the muscle anatomy and therefore in terms of the functionality of the pelvic floor itself. So please remember, in all these patients, the first thing you do is identify these facial reflections and see whether there's something going on in terms of the plexus, which is also located posterolaterally. Once you've got the basic anatomy that this is visceral, this is parietal endopelvic facial reflection, what you need to know is the facial reflection doesn't stop here, but the facial reflection goes all the way down and kind of sits on top of what I call the pelvic diaphragm. So this structure is the pelvic diaphragm sitting out here. So the facial reflection kind of merges on top of the fascia, condenses on top of the levator ani, which is also called the pelvic diaphragm. Now, one thing to remember is these facial reflections are also kind of reinforced at two specific locations. Now, what are those locations? The two specific locations where they're typically reinforced, especially in women, is where you have the anterior facial reflection, which is in relation to the posterior surface of the pubic symphysis, and this structure is called the pubocervical fascia. Now, this endopelvic facial reflection tends to kind of form a U-shaped arc, which basically kind of catches the cervicovaginal junction and arcs with two limbs going all the way anteriorly and attaches onto the posterior surface of the pubic or the parasymphyseal region. Now, this arc of fascia is very important because it tends to get damaged when you're having in terms of childbirth and so on and so forth. And they are also so the damage to the fascia during that time is a very preponderant reason why you can develop cystocele. Now, this is very important. So always look that the arc is maintained in these structures. In the second session, which will be tomorrow, I hope my colleague, Dr. Swaroop, may be showing you some more anatomy in terms of the pubocervical fascia. The second facial reflection, which is a second condensation, which you should know posteriorly. So anteriorly, you have the pubocervical. Posteriorly, you have what we call the rectovaginal facial reflection. Now, both these facial reflections are just condensations of the endopelvic fascia, and they reinforce the pelvic floor so that it tends to maintain the laxity when it's required and also maintains the tautness when it's required. So please remember, visceral endopelvic fascia, parietal endopelvic fascia. The visceral endopelvic fascia covers the extraperitonealized component of the rectum and partly the prostate, where you have called it the Denon-Villiers facial reflection. I'm not getting too much into the anatomy of the prostate at this point. The parietal endopelvic fascia is along the pelvic side walls, and the posterior aspect, it is called the condensation, is the typical facial reflection, also called the presacral fascia. Reinforced at two locations, the pubocervical fascia and the rectovaginal fascia. Now, it's always remember that the perineal and the pelvic floor anatomy is more complex in women than what you see in men. Men, it's a little more straightforward and not too difficult to understand. So now, how do we divide the perineum and therefore getting in towards the pelvic floor itself? So by and large, when I look at the perineum, I'm looking at structures which are ideally located between the pelvic floor, which is what we're looking as the levator ani out here, and what you have on the sagittal plane, if I were to kind of just show it to you, is a structure which is located all the way up to the level of the anal verge posteriorly. And here in women, you would look at the introitus. In men, you would be looking at the penis and the scrotal sac. So if you're looking at the anatomical classification of the perineum, I've not put a female anatomy out here, but I will try to do that in a matter of few minutes. Just give me that time. If I can just pick up a female anatomy of the perineum. Okay, I'll first finish the male anatomy and then get back to this. It's kind of complicated otherwise. Just give me a second. Okay, so let's finish the male anatomy. So kind of looking at it from an easier, simplistic perspective. So by and large, what I would do to divide the perineum is divide into two components. You would have a central component, which a central structure which divides it into an anterior and a posterior compartment from an anatomical standpoint of view. So this central structure which you see out here is also called the perineal body. So now I call this the central strut. It's a very critical structure to identify. How do you identify it in males? It's easy to identify. The apex at which the bulbospongiosus and the ischiocavernosus meet, along with what we call as the rectoprostatic shelf. This interface is called the perineal body. Now, the perineal body serves as an attachment to numerous structures. Anteriorly, like I said, the penile bulb and the crura, which are the ischiocavernosus. Posteriorly, you will have the external sphincter complex. Superiorly, you will have the levator ani muscle coming in over there. And then, of course, you have your transverse perineal muscle also kind of coming into that location. So all these structures basically kind of condense and meet at the perineal body. Now, if you're going to look at the perineal body by and large, and you would use that as a center, it's a very blackish structure. I'm going to kind of increase the brightness of this image. This is the perineal body. Okay, so this typically you have the anal canal, and here you have the bulbospongiosus, and here you can appreciate the superficial and the deep layers of the transverse perineum, one above the other on the axial plane itself. The anterior, the structure which is located ventral to the perineal body is called the anterior urogenital triangle. Now in men, it's a very, very little more complex structure simply because you have a component which is located above the urogenital diaphragm, and you have a dominant component which is located below the urogenital diaphragm. In women, it's a very short transition zone, but it tends to have a lot of structures packed within it within a very small space. So the complexity in women simply is because of too many anatomical structures within a very small space, whereas in men, the urogenital triangle of the perineum is more larger in size, and of course, therefore, has got a more, the anatomical variations are also substantially more when you kind of look at the facial reflections. The posterior compartment, which is located behind the perineal body, is also called the anal triangle. So in this part of the lecture, I won't be looking at so much in the anal triangle. I'll leave that for a later point in time. I'm going to focus on the urogenital triangle, which is very, very important to identify in these patients. Okay, So let's kind of look at the anatomy of the urogenital triangle, and then we will kind of go back also onto the key structures above and below. Uh, One small thing to explain to people or to radiologists and my colleagues and my students out here is the anatomical classification of the perineum is slightly more different than the functional classification of the perineum itself. So what I mean by that is, when describing the anatomy of the perineum, you would divide it in relation to the perineal body. So you would have an anterior compartment and a posterior compartment. But the functionality is slightly different, especially when it comes to women, simply because you have a central compartment, which is the vagina and the vaginal introitus. So from a functional point of view, in women, the perineum is divided into three compartments: the anterior compartment, which is the bladder, the urethra, the urethral sphincter, and the urethral meatus; a middle compartment, which is the vagina, with its, I'm not talking about the fornix of the cervix, it's just the lower 2/3 of the vagina, and the vaginal opening, which is also called the introitus. And of course, you have the vulva, which is the composite of both these structures. So that's the medial compartment. And then the posterior compartment is the anal canal and the sphincter mechanism. So all these three compartments can have their own unique interplay, and you need to know each of them very carefully. I'll finish the male perineal anatomy, and then if I'll try to pull out a case of a female anatomy and describe that to you all also in great detail. So how do we kind of divide the perineum? Now, the perineum is not divided by the level of the perineal body, but the perineum is divided by a structure which is called the urogenital diaphragm. Now, this urogenital diaphragm is a very key structure which you should know. It basically kind of subdivides the so-called potential space into two compartments. And how it does it divide is what I'm going to explain to you in the next minute. By and large, what happens is the urogenital triangle is divided by a key structure, which is called the urogenital membrane or the perineal membrane. Now, this perineal membrane divides or kind of, you would say, breaks it down into two so-called equal compartments, especially in women. What is located above the perineal membrane is called the deep perineal space or the deep perineal pouch. What is located below the perineal membrane is called the superficial perineal pouch or the superficial perineal space. So to get that again, very important to remember: urogenital diaphragm, perineal membrane. Perineal membrane, what is located above that is the deep space. What is located below that is the superficial space. Now, these are two important structures because each of them tend to have their own individual communications and their own individual contents. Now, each of them have to be very carefully analyzed when you're kind of looking at these structures. So let's look at the superficial perineal pouch. It's much more easier to understand in men because of its larger size as compared to the deep perineal pouch or the deep perineal space. The superficial perineal space or pouch is an open compartment. Now, please understand the terminology. Where is it open is what I'm going to get to you at. The superficial perineal space is bounded rostrally by the perineal membrane and caudally by a facial reflection. I hope you'll remember your anatomy. That fascia is called the Colles fascia. The Colles fascia is the fascia which is the inferior boundary of the superficial perineal pouch or the superficial perineal space. Now, please remember the Colles fascia becomes contiguous with two separate structures which are independent of each other. But when there is a pathology, lesions in the superficial perineal space can migrate or can go to these locations. Antero-inferiorly, the Colles fascia is contiguous with the dartos. The dartos, if you'll remember very carefully, is intimately related to basically what you have. The dartos fascia is related to the scrotum and to the penile shaft itself. So now you understand that when you have a space which is potentially communicating with the penis, pathologies which breach the urogenital diaphragm, like a CA prostate, has a high potential chance of actually getting into the penile shaft itself. So please remember, perineal membrane is the roof of the superficial perineal pouch. The inferior margin is formed by the colles fascia. The colles fascia is open anteriorly. Therefore, it communicates with the dartos, which is part of the scrotum, as well as part of the penile shaft. I'm not going to get too much into the dartos fascia. That's for a later time. What else is the superficial perineal space communicating with? The superficial perineal space also communicates with a potential space which is located between the external oblique aponeurosis, deep, and superficially the superficial layer of the fascia of the anterior abdominal wall. Now, what is that facial reflection? That facial reflection is called the Scarpa's fascia. So if we go back to your anatomical days, you'll remember that there are two facial reflections which are located above or ventral to the external oblique muscle, which is the anterior-most muscle of the anterior abdominal wall. The superficial layer of that is called the Camper's fascia. The deep layer is the Scarpa's fascia. There is a potential space between the Scarpa's fascia and the anterior fibers of the external oblique aponeurosis. So now you have pathologies which are located in the perineum, which can go migrate antero-inferiorly into the scrotum of the penis, or could migrate ventral to the pubic symphysis and could lie between the facial reflection of Camper's and Scarpa's and the external oblique aponeurosis. So this is very important to remember when you're looking at anatomical pathologies involving the urogenital diaphragm. So how do you come to know whether it's deep or superficial? It's simply by way the disease spreads along these facial reflections. Now, what are the structures which are contained within the superficial perineal space? The superficial perineal space, typically when you look at the male, would contain the bulb of the penis. So the bulb of the penis, which is located here, which is where you tend to get the transition zone between the membranous urethra and the penile urethra, or what we call at the penomembranous junction between the anterior as well as the posterior urethra, is the key structure in men. Along with that, you tend to have what we call the ischiocavernosus, which then prolong anteriorly to form the crura, the corpora spongiosa, and therefore the corpora cavernosa. So these structures are very, very important to remember. The bulb of the penis, and of course, the crura of the penis as well. So what we call them in a very simple way is the erectile tissue in men. Now that is contained purely within the superficial perineal pouch. What is the other structure? The superficial transverse perineae is also a very important structure. Now, if I were to show you where the muscle is, that is the superficial transverse perineae, which you can see in this location, attached to the perineal body and intimately related to the bulb of the penis. This is the key structures which are located out here. Of course, within the bulb of the penis, you would have you'll have the beginning of the anterior urethra, which is coming up out here. So these four structures are very, very vital when you're assessing the superficial perineal space. Why is it also important? That when you tend to get pubic or subpubic fractures, you have a high tendency for injuries to these structures within the superficial perineal space. You may see hematomas there, and the pattern in which the hematoma migrates or tends to dissipate is going to be telling you where exactly the injury is located. Once you're done with the superficial pouch, you need to go to the deep pouch. Now, the deep pouch is basically a very, very small space which is located above the perineal membrane. So you know the perineal membrane is the dividing space. So you have what we call the perineal membrane, which kind of divides it. Above that is the deep space. And then you have what we call the superior fascia of the urogenital diaphragm, which then divides this into two components, divides it into a horizontal plate where you tend to get the deep structures like the deep transverse perineae. And of course, in men, you tend to get the external sphincter complex, which is very important. That's the external urethral sphincter complex. And of course, you also have the membranous urethra. So the transition zone of the urethra between the prostatic and the penile urethra, what we call the membranous urethra, is in the deep perineal space. Now, this deep perineal, naturally, because that urethra has now gone beyond the autonomic sphincter, what you have the muscle surrounding that sphincter in males is the external sphincter. In female, also you'll have what we call the urethral sphincter. Now, one easy way to remember how to identify the sphincter is that you should be able to see what we call the if I were able to show you this, 1 second. So this is as simple as you can get, the 4-layered part of the sphincter. This is the external sphincter. which you can see as a black stripe. Deep to the external sphincter, you have a brightish layer. This is a composite of two structures, that is the internal sphincter complex or the smooth muscle complex and the submucosa. Below that, what you have, the dark or the darkish gray lining, is the mucosal lining, which you can see here. And then you have the core of the urethral cavity or the lumen, which is brightish in signal itself. So that is the classic four-layered pattern, which you're kind of envisaging of the urethra. Now this, like I would tell you, is the level of the membranous urethra. You can see it below. The apex of the prostate gland sitting here. This is the bulb of the penis. And so this would be the transition zone. And ideally, this is the classic four-layered concentric pattern of the urethra you should be able to identify at this transition zone. The lack of identity of this sphincter complex usually is a poor harbinger in terms when you're looking at laxity in and around the urethral sphincter itself. You should see this condensation of the fascia sitting up here. This is the pubocervical facial reflection, which is seen at this location. And of course, anteriorly, you have a combination of the puborectalis muscle, which is kind of condensing along the subpubic arch sitting up here. Now, in the male, you would not typically call it the pubocervical fascia. You would call it the puboprostatic fascia, which tends to arc from the level of the prostate gland and goes all the way up to the subpubic arch. So these are very key anatomical structures which you should know in these patients. So I'll just revisit this in a short way, kind of making you all understand. You have basically three components. You have the prostatic urethra, which is typically located in the extraperitoneal compartment of the pelvis. You have the membranous urethra, which is a very short transition zone, which is located in the deep perineal space. What are the boundaries of the space? The perineal membrane inferiorly and the superficial fascia or the superior fascia of the urogenital diaphragm rostrally. What else is there along with the membranous urethra is the external sphincter complex. I've shown that beautifully in this section, and the deep transverse perineal muscle, which you can see in this location. What do you have immediately below that? Anything below the perineal membrane is a superficial perineal space. It's bounded inferiorly by the Colles fascia, which tends to continue anteriorly with the dartos and anterosuperiorly with the fascia of the scarpa, which is the fascia which is intimately related on the superior aspect of the ventral surface of the external oblique aponeurosis. So this kind of briefly tells you about the urogenital diaphragm and its two compartments. Let's go to the next compartment, which is located out here, which is the anal triangle or the anal compartment. So the anal triangle or the anal compartment, you actually want to identify three muscle groups independently. This is going to take some portion of the lecture itself. We will divide this into three integral structures. The first structure which you see, which has got the umbrella appearance, you can see this appearance out here. That's the umbrella, is the levator ani complex. The muscle which is located as a condensation right below that, I'll kind of magnify this image. You can see this condensation of a muscle sitting up here. That muscle is the puborectalis. And then, of course, below that, you have the external sphincter complex itself. So in the anal triangle, you have three basic muscle complexes which you need to look for. Now, when I'm talking about this, I'm going to discount one muscle which is located straight away, which you can actually identify very, very clearly, and that is the coccygeus muscle. Now, many people think that the levator ani is comprised of four muscles, not three. But actually, the factual nature of the thing is the coccygeus muscle does not have a role to play when you're looking at the levator ani itself. Now, this is an independent muscle which is typically located along the lateral aspect of the lower third of the sacrum and the coccyx, and typically attaches to the sacrospinous ligament. And therefore, this muscle is not related to the pure levator ani complex. So now let's identify what are the parts of the levator ani itself. Now, this is very important because when you're looking at pelvic floor anatomy, I think Dr. Swaroop will be talking about pelvic floor disorders tomorrow, is that you have to look for certain key structures in the muscle in terms of morphology, in terms of symmetricality, in terms of signal intensity, in terms of muscle bulk, which is very, very important. So in a good number of patients, the muscles may be symmetrically thinned out. That does not mean the muscle is abnormal. But when you get an asymmetric muscle process, you tend to see diffuse thinning, or sometimes a patchy areas of thinning, or even discontinuity of the muscle. That's of significant importance. So therefore, it's very important for you to identify each component of the levator ani, because you need to predict which component of the muscle is actually the problematic component when you're looking at pelvic floor diseases. So by and large, the levator ani is divided into two major structures, and which is reinforced posteriorly by the third muscle group. Now we'll start from anterior to posterior, and anterior to posterior, what you would be having is the two major groups. So first one is the pubococcygeus. So as the name tells you what it is, it's basically a fan-shaped group of muscle fibers which are horizontally, literally it arises horizontally and then arcs kind of posteriorly, where it tends to meet with the second component, which is the iliococcygeus. So the pubococcygeus ideally arises from what I called as the subpubic arch, or the pubic, you would say the inner margin of the pubic symphysis, or the inner surface of the pubic bone itself. So if you would look at this inner margin is what I'm trying to look for when I'm always looking at the muscle, which is the pubococcygeus component. Now this component, again, what happens is it tends to come or arc a little more laterally, and where it tends to arc laterally, you need to see its relation to an important muscle, which is the obturator internus, and the facial reflection, which is seen above the obturator internus. So whenever you're looking at these cases, look at where the muscle is arising from the posterior surface or the inner surface of the pubis, and trace it all the way back to the facial reflection, which is on top of the obturator internus muscle. That is the typical origin of the arc of the pubococcygeus muscle. Now, this pubococcygeus muscle does not just float in the air, but basically what it does is it tends to arc down, and then it kind of condenses at the perineal body, which is located here. So if you can see carefully, the arc which is going up is basically the condensation of the pubococcygeus muscle, which is arising from the pubic arch, the posterior surface, and the obturator fascia, and arcing downwards to meet at the perineal body. Simultaneously, what happens is its posterior fibers tend to decussate with the second muscle group, which is also called the iliococcygeus muscle. Now, this iliococcygeus muscle is a pretty interesting muscle because it tends to have a wider arc of origin of the muscle itself. So if I were to trace this muscle, you would actually have to go all the way posteriorly to the coccyx, or the coccyx bone, which you see here. Then you can see this broad arc-like structure, which tends to form an umbrella more laterally. And this basically tends to form an arch, which extends between two critical structures. One structure is called the ischial spine. So if you'll remember your anatomy very well, ischial spine is different from the ischial tuberosity. The ischial spine basically divides the greater from the lesser sciatic notch. Now that's very important when you're going to talk about the lumbosacral plexus and its nerves and so on and so forth. So please remember the iliococcygeus muscle, is intimately related to the coccyx tip, to the ischial spine, and the posterior aspect of the obturator facial condensation. So please remember, whenever you're looking at the levator ani, always look at the obturator internus itself. And you would always find that the lateral aspect of the levator ani muscle tends to go all the way to the edge and tends to meet up onto the condensation, which is seen over the obturator internus muscle. This is a very important structure. You would see this like a seagull appearance. The disruption of this structure out here usually leads to defects in the levator ani, and therefore you may get pelvic floor abnormalities or pelvic diaphragm abnormalities, which could be unilateral or bilateral. So very important to remember, kind of identify this facial continuity very, very well. So that's basically talking about the two major muscles, that's the pubococcygeus and iliococcygeus. What is the third muscle? Now, this muscle, which I'm going to explain to you now, is probably the most critical muscle in the entire group of the pelvic floor structures, which you need to know. And that is called the puborectalis muscle or the puborectalis sling. Now, this puborectalis sling basically gains origin from a critical structure which is called the ischiopubic ramus. And this fan-shaped, or would say a U-shaped muscle fibers tend to come out from the ischiopubic ramus and tend to circle or encircle the posterior wall of the rectum. It's not a complete circle. It basically kind of hooks along the posterior edge of the rectum, and it kind of forms a condensation along the posterior margin. So I'll just kind of show it to you on the sagittal. Here, I've just magnified the image pretty well. I'll just put the T1 coronal out here for you all to appreciate the muscle very clearly. So I'm going to go back. You see this muscle group here, which I've kind of annotated. That is the puborectalis. So I'm going to move first off center to the sagittal aspect. You can see the fibers coming out from the ischiopubic ramus. And these fibers then tend to arc over and form a condensation along the posterior wall of the rectum. Now, this junction, where it tends to form this kind of a U-shaped kind of a notch on which the rectum lies, this is basically also called the anorectal junction. And this structure, where the levator ani kind of forms this form of a shelf with the puborectalis, is called the levator shelf. Now, all these structures are absolutely critical when you're going to understand the anorectal angle, the rectal ampullary pressures, the defecation maneuvers when you're looking at a squeeze, strain, and then, of course, the defecogram itself. So this muscle out here, this condensation, is very critical to maintain the functionality of the pelvic floor itself. So I'm going to quickly reiterate this whole thing again. The levator ani has got three components: the pubococcygeus, the ileococcygeus, and the puborectalis, which is again the condensation, which is located caudally to the main muscle group itself, reinforces it, has a U-shaped structure, supports the posterior rectal wall, gives rise to what we call the levator shelf, and also gives rise to the anorectal junction and the arc, which is very, very critical to understand in terms of anatomical continuity. Once you're done with the levator ani itself, please remember the levator ani is very unique in two things. The levator ani basically has got two different types of nerve supply. The levator ani has got a supply to the pelvic component, which is by a different nerve fiber group as compared to the, the undersurface, which is called the perineal aspect. The perineal aspect is supplied by the pudendal nerve. The pelvic aspect is supplied by the ventral rami of the lower sacral plexus, which is typically the S3 and S4 trunks. So please remember, S3 and S4 supplies the pelvic aspect. The perineal aspect is purely supplied by the pudendal nerve. So this is very important to remember. So once you're done with the levator ani, second thing is the puborectalis. The third component is the external sphincter complex. The external sphincter complex is divided into three components. The lowermost component, which is located at the level of the anal verge. So this is the internal sphincter. This is the anal verge. This is what we call the subcutaneous fibers of the external sphincter complex. The muscle fiber group, which is just located a little more rostrally, you can see that in that gap over there, that is the superficial fibers of the external sphincter, and the deep fibers are located a little more rostrally, and they tend to merge with the inferior fibers of the puborectalis itself. So if I were to look at it again, subcutaneous, superficial, and the deep fibers of the external sphincter complex. So what I've done over the last about 40 odd minutes is kind of touched all on the facial anatomy and the major muscle anatomy, which you should know as a resident doctor if you're planning to read these cases at any given point in time. I'll try to just give me about a second. I'll try to look for a case on the female anatomy of the pelvic floor, and then we can just about, so I'll give you a 2-minute break, and then I'll just come back to you all again. Okay, so I've got a nice case out here of the female anatomy, which you'll require when you're trying to identify the urogenital diaphragm. So again, getting back onto a standard anatomy class appearance. So in women, it's 3 compartments, as I mentioned to you all. I'll kind of draw the line. So you have what we call the anterior compartment. You have the posterior compartment, which is a sandwich between the anal as well as the bladder and the urethra, which basically contains the vagina and the introitus. This is the anal triangle, which is located a little more posteriorly. Please remember that the urogenital diaphragm is a little more complex in women simply because a very tight and a close-knit space where you have too many structures located within that space. So kind of looking at the female anatomy or the female counterpart of the same, pretty much easy. You know that the urethra is very short. So that is the classic urethra, you would explain. I kind of showed you all the 4 layers of the urethra on the actual images. You can appreciate that even better out here. I'll just revisit that in terms of the female anatomy. That's external sphincter. That's the so-called smooth muscle complex with the submucosa. You have the mucosal stripe, which is in orange. And the last one, which I've got, is the bright stripe of the urethral lumen itself. That's pretty much. As I mentioned, the condensation of the facial reflections getting up here is the pubocervical fascia. Now, this is very important because any damage to the pubocervical fascia is going to cause cystoceles. Now, that support to the urethra and the bladder, inferior bladder wall, is very, very important to prevent the anterior compartment prolapses. The second structure, which is located behind out here, so you have the vagina, which is kind of looking like a layered salami as a sandwich with a salami in between. So what you again appreciate this very nicely is the 4-layered appearance of the vagina itself. So if I were to look at it from an anatomical point of view, that is purely the striated muscle, which is located out here. You can see the striated muscle. This inner layer is the submucosal component, and the blackish stripe, basically, which is located, is the stratified squamous mucosal epithelial lining with the lumen of the vagina itself. Now, you should be able to identify all these structures because when you have patients who have had pelvic floor injuries or prior surgeries, or you would have had prior, you would say, scars which have happened at the time of childbirth, the disruption of this normal anatomy of the vaginal wall, and therefore the rectovaginal shelf, is a very key indicator of what's happening in that area when you're looking at pelvic floor injuries. So coming down to the level of the introitus, this is where the challenge really comes out for most radiologists, is trying to identify the key structures in these areas. So if I just show the anatomy of the area, just to reiterate it, that is the clitoris, which you can see pretty well. That's a clitoris. The clitoris is the female counterpart of what you would look in terms of the bulb. And what you would have, therefore, you would have the bulb of the clitoris, which is a central portion. And you would see these 2 blackish structures, which are arc-like structures going all the way towards the pubic arch or the ischopubic arch. And that is basically the crura of the limbs of the clitoris itself. Now, what happens just ahead of that, or just below that, you would say in terms of front of that is the mons pubis. And of course, posteriorly, what you would be having is the level of the anterior and the posterior fourchette. This is the anterior fourchette. This is the posterior fourchette, which is located in relation to the introitus or the vaginal orifice, which is located out here. Ideally, when you start coming down below the level of the orifices, you will start to see the mucosal fold. You see the 2 fat-laden folds of the labia minora and the majora itself. So when you come down all the way down, that is the labia majora, which you can see as a continuation of the fat from the medial aspect of the thigh. Just give me a second, guys. Just give me a second. Huh? Yeah, sorry, there was a small interruption. So I'll just reiterate this. The labia majora is basically a fold of subcutaneous tissue which contains a fat which is contiguous with the medial compartment of the thigh and portions of the ischoanal fossa and the gluteal region. Parting the labia majora, what you have is the labial minora folds, which are located out here. And now between those two folds, what you tend to have is the vulva, which is covered, which is kind of contains what you have anteriorly. You have the clitoris, which is the muscular body, along with its true limbs, which are the crura. Posteriorly, you would have the vaginal introitus, which is sitting up out here, and the posterior fourchette. And in the two, between the two, you have the urethral orifice or the urethral meatus, and therefore you will have you can trace that upwards to the urethral sphincter. Now, please remember, all these folds, all these muscle layers are very, very critical, and you need to identify each of these structures before you tend to give a normal report when you're looking at pelvic floor structures. So what I've done is, over the last 50 odd minutes, shown you all the key structures which are located in the central compartment of the pelvis and the perineum. Now, what I'm going to do over the next another about 10 minutes or 15 minutes is reiterate certain important points when it comes to the pelvic side wall, which is equally a very important structure when I'm studying this entire part of the pelvic floor anatomy. So one thing to remember when I was teaching you all the facial reflections is, this is the visceral endopelvic fascia, and this is the parietal endopelvic facial reflection. Now, please remember that there are structures, there are three compartments within the pelvis itself. So you have the true peritoneal compartment, the peritoneal spaces. Then you have what we call the extraperitoneal, or what we call the subperitoneal spaces. The subperitoneal spaces can be again divided as structures which are still intrapelvic, but which are what you would call as contiguous with the retroperitoneal structures. Now there are two of them. So what would be the structure which is going to be contiguous with the retroperitoneal structure? That structure, which are going to be again divided into two areas. One is the mesorectal compartment, and the second one, which is going to be likely contiguous with the extraperitoneal. So you have this, which is intra, this which communicates with the retroperitoneal, and then you have something called the extraperitoneal space, which then basically goes along the pelvic side walls, lateral and posterior lateral pelvic side walls, which will arc rostrally along the undersurface of the parietus, but ventral to the parietal peritoneal reflection, and that is called the properitoneal fat. Now that I'll kind of show it to you all on the sagittal image, and you can appreciate that very beautifully out here. So you have the retropubic space of Retzius, which continues with the properitoneal fat space out here. So by and large, so if I were to teach you all pelvic spaces, it's peritoneal, subperitoneal, retroperitoneal, and subperitoneal, extraperitoneal, which are very important things to remember. So now let's look at that subperitoneal, extraperitoneal compartment, which is very, very important to remember when you're looking at pelvic floor. And the pelvic floor anatomy, why? Is because that contains the lumbosacral or the sacral plexus. That sacral plexus is, like I've said, is a condensation of two major nerve groups. The nerve groups which are arising from the ventral rami or from the anterior neural foramina of S1 to S4, and the ventral rami condensation of L4 and L5 constitute what we call the lumbosacral or the sacral plexus. Now, pathologies which tend to affect the lumbosacral plexus will also affect the pelvic floor itself, will have issues related to, because you know that the upper portion of, or the pelvic compartment, the pelvic surface of the levator ani is supplied by the S3 and S4, which is part of the lumbosacral plexus, whereas the inferior aspect is supplied by the pudendal nerve. So please remember, whenever you're studying these plexus or these, you need to see these individual nerve root fascicles, which are separated by what we call intra, or you would say intrafascicular fat. So I'm not going to get into the anatomy of the nerve, into the epi, the peri, as well as the endoneurium, but by and large, these are basically large fascicles of nerve fibers which are separated by fat. So one of the things to remember when you're looking at lumbosacral nerve plexus is always look for the symmetricality on how these fibers are actually splayed across. And I'll just show you how the nerve fibers are. So this is the nerve fiber group. Look at that. This is the nerve fiber group. And ideally, you get to see these individual fascicles, which are beautifully linearly splayed by a similar quantum of fat. And this is very sine qua non of a normal lumbosacral plexus. Also, please remember, by and large, most of these plexuses, when they tend to amalgamate or they get together, they will have a subtle stir signal, which is slightly bright on the stir images. And we as radiologists love to use fat suppressed sequences and stir sequences. And anything which appears bright, we tend to call it pathological. It's not the nerve which is pathological, it's our mind which has become pathological. And what I mean by that is not everything which is stir hyperintense is really a neuritis or a plexopathy. So you've got to be very careful when you're looking at the nerve plexus itself. So the first thing you look for is symmetricality. Look for preservation of the fascicular, intrafascicular fat or interfascicular fat. Look for the equidistance. If the nerves are splayed, or if the nerves are aggregated or clumped together, you need to start worrying whether there's some form of a plexopathy coming up in these locations. Also, please remember that these nerve roots extend primarily through the greater sciatic notch, and that also is divided into two components by the piriformis muscle. So in all your patients who tend to have pelvic floor abnormalities or certain kind of issues, look at the piriformis muscle very keenly to see whether it's hypertrophied or atrophied. Is it symmetric or asymmetric? And see what is the impact of that muscle. Because the muscle divides that notch into a superior compartment and an inferior compartment. Certain nerves go above into the superior compartment, certain nerves go below in the inferior compartment. So the lumbosacral plexus is very important to remember, to identify. I've not shown you this. I don't have an image of this right now. Probably I'll ask Dr. Swaroop to show you all. Is that it's also important that when you're studying pelvic floor, that you also just have a slight look at what's happening at the level of the psoas major muscle. Now, why is the psoas muscle very important? Is the lumbar nerves tend to actually come out and get into the muscle or traverse in relation to the muscle itself. And that is the L1 to the L4 nerve roots. Majority of them will pass medial and posterior to the muscle. Some of them will go through and through the muscle. So whenever you tend to get injuries or damages to the psoas muscle itself, you can also damage your lumbar plexus, which is the anterior rami of L1 to L4. So that kind of takes care of the lumbar plexus. When you're tracking it down, you can see that the plexus tends to continue down as the sciatic nerve, which traverses in a retroacetabular location, posterior, or so do you say, deep to the gluteus maximus muscle itself. Again, the nerve can have a subtle bright signal on the stir images. So you've got to be very careful before you call it a pathological condition. So kind of envelop not only the central component, but I've also shown you all the pelvic side wall. Once I'm done with just the basic anatomy, it's very important to get back to what we call as keen lines or structures which you cannot miss when you're studying the pelvic floor. So let's look at it from a topographic point of view. So until now, the entire discussion was on the coronal plane or on the axial plane. But you need the sagittal, which is the key sequence when you're trying to assess pelvic floor disorders. So though we are used to seeing anatomy on axials, as well as on coronals not many people are good at, but sagittal is a very, very important sequence because it gives you a very good side-on view on what's happening to the pelvic floor, especially during dynamic maneuvers. So just for 1 second, I'll just identify all the key structures so that you'll kind of know what we're looking at. So this is the anterior parietus, the infraumbilical anterior parietus. There are two facial layers which are located along the ventral aspect of this. They are respectively camper and scarpa. I've just explained that to you all. The scarpa is contiguous and gets down below along with the colles fascia. The colles fascia kind of envelopes the scrotum and the penile structures with the dartos fascia. The colles fascia is inferior. The superior, so you know that that's the inferior part of the perineal space or the perineal pouch. The superficial perineal pouch is walled inferiorly by the colles fascia. rostrally by the perineal membrane, contains the penile bulb and the crura, and of course the anterior most section of the penile urethra, which transgresses just beyond the perineal membrane for a length of about 3 to 4 centimeters. So this is the superficial perineal space. This very small narrow space between the perineal membrane and the superior fascia of the urogenital diaphragm, which is basically located just below the apex of the prostate gland, is the deep perineal space, contains 3 critical structures: the membranous urethra, the external sphincter complex, and the deep transverse perineal muscle. Both of them tend to condense posteriorly into one blackish structure, which is called the perineal body, which gives attachment to the levator ani, the external sphincter complex, the superficial and the deep transverse perineum, and the bulb of the penis itself. So these are 3 vital structures which you see here. Of course, the levator ani, the puborectalis, the external sphincter complex, and all of these structures now have actually formed what we call the combination of the pelvic and the urogenital diaphragm. The coccygeus muscle, which is little more off lateral and gets attached to the sacrospinous ligament, is not part of the levator ani. This structure which you see out here is the anococcygeal ligament, and you will see that condensation of the levator ani fibers kind of merging in the midline raphe over there. This is the presacral fascia, also a continuation of the parietal endopelvic fascia. This guy, which is enveloped the mid-rectum, the facial reflection is the mesorectal fascia. And if you remember my previous lectures, this is the anterior peritoneal reflection. So you have true peritoneal space, you have subperitoneal space, but which is contiguous with the retroperitoneum, and then you have extraperitoneal space, which then continues with the properitoneal fat pad, the retropubic space, so on and so forth. So now let's kind of look at the major lines, which Dr. Swaroop again will reiterate tomorrow based on some live cases. The first line which you should remember whenever you're studying pelvic floor is what we call the pubococcygeal line. Now, the pubococcygeal line is typically drawn from the midline. So you have to get your axial images. Reach up there, get your sagittal, get it bang on the center. Once you're done with that, take out the axial and identify the inferior cortex of the pubic symphysis or the parasymphysis region. You start your line at that location. So that is the anterior most aspect of a pubococcygeal line. And then what you need to do, you got to look for the last coccygeal joint. So what we call the last coccygeal joint is typically seen here. And the line which is drawn from the inferior edge of the pubic symphysis all the way up to the last coccygeal joint is called the pubococcygeal line. Now, what is the importance of the pubococcygeal line? The pubococcygeal line basically is a demarker for pelvic floor descent. So as the pubococcygeal line changes, it is an indirect marker whether or not the patient has got a pelvic floor descent abnormality or not, or a pelvic floor weakness. Now, this is very important because this line typically goes along the inferior most edge, or generally tends to cut through the condensation of the levator ani muscle along with the puborectalis, what I call as the levator shelf. Now, this levator shelf, which is seen out here, is a very key structure when you're going to identify pelvic floor anatomy. Now, why is it so important? This levator shelf is basically the condensation of the puborectalis, which tends to pull on the posterior surface of the rectum and give it that tug and allow it to hold it towards the subpubic arch. Now, when this angle kind of changes, it allows you to squeeze, strain, or defecate. So this structure, the transition zone, is identified by the pubococcygeal line. So what are all the structures identified by the pubococcygeal line? The first one, which I'm going to mark out here, is the levator shelf. The second is the transition zone between the patulous rectum, which tends to narrow down and come below as it gets squeezed between the puborectalis, what I call as the anorectal junction, very important, and therefore the transition between the lower rectum and the anal canal. Now, this is a very critical structure. So once you're done with the pubococcygeal line, what all should you also know along with the structure? So that's the first one which you're looking out here. It's not to the tip of the coccyx, it's not to the sacrococcygeal junction, It's the last coccygeal joint to the inferior margin of the pubococcygeal or the pubic symphysis. So now, what is the key criteria when you're looking at the length of the pubococcygeal? Is there a criteria for the length of the pubococcygeal line? No, there is no length, but there's a key criteria when you're looking at pelvic floor descent. In women, when you have the anterior and posterior compartments, the descent of the pelvic floor, if it's by 3 centimeters, for the anterior and the posterior compartment, you subtract about a centimeter each and you give the true value. So you will give it as, if it has gone down by 3, you got to subtract 1 for anterior and middle compartment. If it's gone down by 6, you subtract 3 for the posterior compartment. So for the anterior and middle, you subtract 1. And for the posterior, you subtract, I think, 2.5 or 3 centimeters before you give your measurement. So the pubococcygeal line is an independent demarker when you're looking at the pelvic floor structures itself. So it's very important that you get to see this from both a sagittal as well as a coronal point of view. Please also remember that this line, which tends to go all the way back, if you were to stop the pubococcygeal line at the level of the anorectal junction, this is basically what we call as the H line. So the pubococcygeal line goes all the way to the last joint. The H line from the inferior-most edge of the pubic symphysis and reaches up to the level of the transition zone between the anal canal and the rectum, and what we call as the so-called posterior rectal wall, where you have the transition zone. This ARJ is very important. The length of this line should never exceed 5 centimeters. So what does this line basically tell you? This line is what we call as the pelvic hiatus. This is the hiatus or the opening through which the pelvic structures descend down into the perineum. So this hiatus should never be more than 5 centimeters in a neutral position. If the hiatus is widened, it usually means there's some form of laxity of the pelvic floor itself. So you've got the pubococcygeal line, you've got the H line. What do you have next? So once you've got these two, you have got the anorectal angle. So the anorectal angle, tomorrow Dr. Sarup will again show you. It's basically very easily drawn. That's the anal canal, and that's the posterior wall of the rectum. This angle, which is subtended between these two lines, is called the anorectal junction angle. Now, what is the normal range? The normal range is anywhere between about 108 to about 127 degrees. Some people say 105 to 122, 123, but by and large at our institution, we use the range between 108 to 127. It kind of tends to work very well. Now, a normal hiatus, a normal anorectal junction angle means that the pelvic hiatus is pretty good. The puborectalis muscle is doing its job, and therefore the pubococcygeal line at rest is also going to be essentially normal. What is the next thing which you got to look at? The next thing which you got to identify tomorrow, which he'll show you, is the M line. Now, this M line is a slightly different one when you're looking at it in terms of the anorectal junction and the amount of descent of that anorectal junction when you tend to have a squeeze maneuver or a defecogram maneuver or a defecation maneuver which is performed. That descent of the anorectal junction below the level of the pubococcygeal line or the H line should never be more than 2 centimeters. Now, this line is typically called the M line, and this M line assesses the vertical descent, and that vertical descent should be not normally greater than 2 centimeters. So when you have patients with a normal hiatus, a normal descent, and a normal anorectal angle, that kind of confines to the absence of an overt structural abnormality in the pelvic floor itself. Please remember that the anorectal angle, when you're defecating or when you're squeezing, the variations in the angle are not going to be generally more than 15 and 20 degrees to the upper and the lower limit of your normal angles. So what I mean is, if you're squeezing, it basically means the angle is going to become more acute, and that angle is probably going to go down all the way to about 95 degrees. It's not going to go to 80. That means it's generally an overaction of the puborectalis itself. At the same time, when you're trying to defecate and there's a persistent, that indentation of the puborectalis should go away from the posterior rectal wall and the angle should straighten up. When it's straightened up, it generally again goes up by 15 to 20 degrees. So if your angle is normally 120 degrees, you'll have an angle now which is about 135, max 140. It generally does not go much beyond that. So please remember, these are the major anatomical structures and lines which are going to go off. So what I'm going to do in the next 5 minutes is quickly just review all of this, and then we'll end up for the day in terms of the anatomical session. And tomorrow we'll have the live case reads of all the pathologies. So quick recap: visceral endopelvic fascia, parietal endopelvic fascia, 3 compartments, again describing it to you all: true pelvic peritoneal spaces, subperitoneal, retroperitoneal space, and subperitoneal, extraperitoneal compartments. The pelvic floor is formed by the levator ani, 3 components: pubo-iliococcygeus, puborectalis. The coccygeus muscle, the 4th muscle, does not play an integral role. Urogenital diaphragm, again, it's a very small structure. The urogenital diaphragm has got a deep space and a superficial space, which is kind of divided by the perineal membrane. The superficial perineal space is contiguous with structures in the scrotum and the penis in the males, and with the anterior abdominal wall ventral to the external oblique muscle. It also goes down into the thigh, which I've not kind of explained to you at this point in time. The puborectalis is the integral part of the external sphincter complex, which is very important to maintain the anorectal junction and the anorectal angle, also called the levator shelf. The pubococcygeal line is very critical to identify the levator shelf. It's a good marker of both pelvic floor descent and also the hiatus. If it's less than 5 and the descent is less than 2, it usually means a good pelvic floor anatomy which is going on, which is there for the patient. Other important structures to always remember is the perineal body. Very important to also identify. In men, you have the rectoprostatic shelf. In women, you got 2 shelves, which is the rectovaginal shelf, and of course, you have the vesicovaginal shelf. Each of these are very important. The vesicovaginal shelf is reinforced by the pubocervical facial reflection. A laxity of the pubocervical fascia or breaks or disruption is going to cause anterior prolapse or anterior compartment prolapse, and you tend to get cystoceles. Vaginal prolapses are more likely a mid-compartment prolapse related to the perineal body, and of course, the levator ani getting dysfunction. And posterior compartment prolapse with rectoceles is a combination of pelvic floor abnormality and of course the vesicovaginal or the rectovaginal fistula shelf from malfunctioning. So that's a kind of a composite or anatomy of the entire pelvic floor. So tomorrow, I hope Dr. Swaroop will be taking about an hour and a half or an hour and 45 minutes on pelvic floor anomalies. Thank you for a patient hearing. Okay, good evening, good night, everybody. Madhu? Anybody there? Madhu's there? Who's there?